All right, welcome everyone to this session of the 2025 Culture of Data Conference. Thank you so much for being here. We will still have some people trickle in, and that's okay. My name is Grace. I use she, her pronouns. I will be your moderator today. We have Naomi Perlman here as our tech host. She's going to make sure everything tech runs smoothly. If you're having any issues, please reach out to her. Everyone's muted right now, so please use the chat for questions during the presentation, and then at the end, we have 10 minutes for Q&A, and you can unmute during that time. If you're comfortable, please add your pronouns to your name. You click the three dots in the bottom of your picture and hit rename. Our presentation this session is about 25 minutes, and then we'll have about 10 minutes for questions at the end. Our presenter today leverages data science to examine the intersection of policy, race, and health outcomes. This research, not only is it quite apropos, but it emphasizes the critical role of reproductive rights in addressing the social determinants of health. I will now hand it over to Kelly DeBee to present Analyzing Racial and Ethnic Disparities and Cause-Specific Infant Mortality in Texas after the implementation of a 6-week abortion ban. Kelly, take it away.
Thank you so much, Grace and Naomi. Thank you everybody for being here today. I appreciate that you've taken time out of your busy day and out of the conference to be with us today. I'm just going to introduce myself briefly. My name is Kelly DeBee. I just defended my PhD a few months ago. So Dr. DeBee, I guess I'm not used to that title yet. This work was done as part of my dissertation. Before I start with anything that I am going to be talking about today, I do like to forewarn everyone that I am going to be talking pretty candidly about two topics that tend to elicit really emotional responses. I will be talking about abortion and I will be talking about infant mortality, and in combination. So if you feel overwhelmed, if you feel like this is too much information or you need to take a break, please do what you have to do to take care of yourself in this space. I fully recognize that this is difficult work. Trust me, I do it every day. So my background is that I have an undergraduate degree in public policy and bioethics, and then I have a law degree. I've done work in public health and epidemiology. So my research really focuses on the intersection of all of those things together. And this piece of the work today is, again, part of my dissertation work. The other sections were on travel, specifically into Colorado for abortion, and the supply of physicians in response to abortion law changes. So I want to start off by saying that as far as the World Health Organization is concerned and most major health organizations, abortion is healthcare, and it is a required component of reproductive health. It's not just about abortion. Reproductive justice really encompasses a bigger, broader scope, and basically with the premise that everyone should have the ability to decide to have children or not to have children, and to raise the children that they have in a supportive and welcoming environment. So, essentially the definition of abortion that we're going to be working with today is that it's the termination of a pregnancy after accompanied by, resulting in, or closely followed by the death of an embryo or fetus. So I'm going to give you a very brief history of abortion in the United States. This is the quick and dirty version. That's not a lot of details, so brace yourselves. Before the Roe versus Wade decision, there were about 800,000 illegal abortions estimated in the United States every year. And from those illegal abortions, there were approximately 200 deaths because of complications of those procedures. In 1973, the Supreme Court decided Roe versus Wade, which recognized a constitutional right to abortion under the 14th Amendment's Privacy Clause. And then the Planned Parenthood case in 1992 shifted to a viability framework. So up until the point of viability, you were guaranteed access no matter which state you lived in. And they started implementing an undue burden standard for restrictions about other requirements that states tried to legislate regarding abortion. So when we see that what we call trap laws or targeted restriction of abortion providers, those are things like how wide your doorways have to be and whether or not a provider has to have admission privileges to a hospital within X number of miles from a clinic. So all of those are judged based on the undue burden standard, or used to be. And then one thing that happened after Roe is that pregnancy-related mortality rates dropped pretty significantly, especially among non-white maternal mortality. Some estimates are in the 30 to 40% drop percentage range for Black maternal mortality, especially. So those are pretty huge implications, right, in terms of health outcomes that we see just from a benefit of expanded abortion access after Roe. However, immediately after Roe versus Wade, limiting abortion access really became a focal point for conservative groups in this country. And when Donald Trump was in his first term, he ran and was elected on a promise to make appointments to the Supreme Court that would be pro-life justices. So as of 2020, we have a conservative supermajority on the court. And once that supermajority was established on the court, a lot of states started to enact trigger bans and laws that were in direct conflict with the law of Roe as it was at the time, some of them with the direct intent to challenge the legal precedent and overturn the decision. So what we get in 2022, not surprisingly, was the Dobbs v. Jackson case, which overturned Roe and relegated decisions about legal access to abortion to the states. So because of this huge shift in the law, we have a lot of what ifs about what's going to happen, a lot of unknowns. Some of the available research that we have to kind of guide what we think might happen would be some of the data like I shared about maternal mortality before and after Roe. We also have a pretty abundant source of research on the comparison of states based on other types of abortion restrictions, such as those trap laws. So those are like your doorway width requirements and admission requirements. There's also the Turnaway study, if you haven't heard of it. It's a really important study in abortion research that looked at people who were turned away from or were accepted and were granted abortions at clinics that were right at the point of the cutoff for whatever that clinic was, and then followed them over time to determine health outcomes. So that's where, kind of where we're coming from in terms of how do we study this. And this really is an unprecedented removal of a constitutional right. And I'm really tired of saying the word unprecedented. I've said it so many times in the last 5 years. I could go for some precedented times, but we are not there yet. And one of the things that happened was that when the Dobbs decision came down, we saw there were immediate impacts on access that happened that day. There were trigger bans that went into effect that day. And a huge amount of variation from state to state, right? So, and that variation hasn't stayed constant either because laws are shifting both at the federal law level and at the state level. And there's been legal challenges based on ballot measures, all kinds of things have been happening. So there's a lot of unpredictability for residents of different states. So for this particular study, why study Texas specifically? The reason that I chose to study Texas actually started with my travel research, which was the first part of my dissertation, because we had such a huge influx of people coming from Texas in 2021. So this is before the Dobbs decision, right? They passed a 6-week ban in September 2021, 9 months before the Dobbs decision, and it was being enforced even though it was in direct conflict with Roe versus Wade because of the way that it was written, and the enforcement mechanism wasn't actually through the state. It was given to individual parties to basically have legal action. So because Texas was enforcing this law 9 months before the Dobbs decision, we have a longer period of time where there's data available to see what happens, right? So there's more opportunity to study things in terms of what happens after the laws change. So for Texas specifically, again, this is they had their Heartbeat Act. It's scientifically inaccurate wording, but that doesn't seem to matter to a lot of legislators. Really what they're talking about is cardiac electrical activity, which is about 6 weeks from the last period, and it's been largely interpreted as a 6-week ban, which is really close to the time that most people find out that they're pregnant. So they also had a waiting period at the time when they had their 6-week ban. So you had to find out that you were pregnant, decide that you wanted an abortion, and then get to a clinic where you still had time to wait out the waiting period before 6 weeks ran, basically, which was very difficult. So it essentially functions kind of as a total ban. They also had a trigger ban on the books that went into effect immediately after Dobbs, but we are not really focused on that because, like I said, their legal access changed 9 months prior. So the hypothesis for this is that there would be increases in infant mortality in temporal association with SB 8, which was that heartbeat law. So why is infant mortality so important? It's because we look at it in epidemiology and in public health as a key indicator of population health. And it has been steadily declining because we have things like clean water and sanitation and vaccinations, right? Huge public health achievements have led to the decline of infant mortality rates over time. And we can see that here in the declining color lines as we go from 1935 to 2015. So overall, it would be that blue line, but then you can start to see the gap between races is changing, right, in terms of the ratio. So these gray bars are indicating the difference between white and black infant mortality over time. So, for anybody who studied public health ethics at all, you know the twin aims of public health. One of them is to achieve better overall outcomes for the population, but also the second aim of the twin aims is to reduce disparities. And so maybe we've done a really good job on that first part, but we haven't done such a good job on the second part, right? So in terms of building this study, we had to think about why abortion access would impact infant mortality. And, maybe one of the bigger, more kind of overarching themes is that abortion access laws are really shaped by societal priorities and the politics in an area that drive a lot of decision making. It's not just the access to abortion necessarily by itself. In addition, the fact that abortion access is restricted, we could be looking at compelling higher risk pregnancies, under-resourced pregnancies, pregnancies and fetuses in pregnant people who are not as healthy as they ideally would be. And so you could see how all of those things might lead to more complications, which might affect infant mortality. Texas also does not have an exception for fetal abnormalities. So that would be a pretty direct line, right, of thinking when we think about how that would be associated. And in general, fetal anatomy scans are usually done around 20 weeks, which is well past the cutoff in Texas, right? If the cutoff is 6 weeks, you wouldn't have any information about any of that yet. And then even the exceptions for the health of the pregnant individual can be really burdensome and difficult to meet. And often it results in them just not being available at all or delayed treatment. And there has been a documented increase in maternal sepsis in Texas that's related to miscarriages in the second trimester because of it. So because this delay in care is actually causing negative health outcomes too. So our outcome of interest is that we have under 1 year monthly mortality counts. This data is from CDC Wonder. So our main models are looking at Texas residents, obviously, because they're the most likely to be affected by Texas laws. But then we have two comparison groups. One is a nationwide comparison using all of the abortion rights protective jurisdictions. So these are states that didn't have any new restrictions before the point of viability / about 24 weeks. And they're all grouped together. I also ran a separate analysis just using Colorado residents for the purposes of this presentation today. So again, these are deaths that occur after a live birth occurs, but before the first birthday. And I have monthly data from January 2018 until June of last year. So the definitions of infant mortality that we use in this work, the main analysis looks at all-cause state-level infant mortality with all the races and ethnicity groups aggregated together. So, but that's not really the most important thing for me because we can see that those trends are still declining, right? Although there is evidence to indicate that overall nationwide infant mortality is actually starting to trend up, which is a huge red flag. But I also was interested in doing a sub-analysis, first based on disaggregation by race and ethnicity group. And then that I also have a controlled model testing the relationships between the race and ethnicity groups. And then for specific causes of death, so the P codes are deaths that are related to specific conditions that originate towards the end of the pregnancy. And then Q codes are deaths that are related to congenital malformations, deformations, and chromosomal abnormalities. So again, there's no exception in Texas for any of those reasons for abortion access. So those were the things that we thought would be the most likely to be related to abortion access. To do this, we use interrupted time series methods. So these are regression discontinuity designs that use repeated observations over time to compare each group of data to itself at different points in time, essentially. And you can establish what the baseline time trend and then estimate what the changes are in association with something like a policy change. So here it's SB8 with a 3-month lag that we added because in order to count the mortality that's associated with this law, those babies have to be born first. So we had a 3-month lag after the change in the law. And for anybody who loves math, here you go. Here's your regression equation. I will not describe this in detail unless somebody has a question about it later. The main thing to know with this is that we're adjusting for time in two different ways. One is a linear time trend, which takes into account changes over longer periods of time, which can absorb like population increases, things like that. And then there's a harmonic term, which accounts for seasonality in the data. Because believe it or not, deaths, births, and abortions are all seasonal. So, okay. So this is the Texas overall crude data. So these are the rates per 1,000 in the population. And as you can see, it's pretty notable from just looking at this that the non-Hispanic Black rate is significantly higher than every other group in the study. So the overall all-cause rate is going to be this kind of salmon line that's in the middle. And then the P codes and the Q codes are those bottom two lines. So those are the cause specific. So those are components of the total. So we would expect them to be lower, right? But the individual groups that are based on race and ethnicity could vary above or below that line. But we can see that the only one that's consistently higher is non-Hispanic Black. And then in terms of our regression modeling, this is actually showing with the adjustment for the harmonic term and the linear time term. So there's a pretty clear increase after SB8, right? So this vertical line, the blue line here, is the date of SB8 happening. We're modeling what happens 3 months later, because again, those babies had to be born in order for that mortality to be attributed in any way to the change in the law. So it's pretty clear and it's pretty striking that, you can see that Texas's trend is kind of going downward over time before that blue line, but then it takes a pretty sudden jump up before it starts to return to a downward trend. And these are the results from those models. So in terms of their all-cause mortality, so this is everybody aggregated together with all causes of death, it was 17% higher after SB8. These are significant values. In terms of the disaggregated data, the highest increase that we found was non-Hispanic Black, which remember, they are starting from the highest existing rate before. So this is each group compared to itself. So for example, for the non-Hispanic Black, so we're only comparing non-Hispanic Black infant mortality in Texas before and after SB8 to itself. So that group again has the highest baseline mortality. So it's gone up 21%. Is what we're finding. And then both of the cause-specific mortality types also showed pretty dramatic increases in mortality after SB8. In a controlled model, however, there was not evidence found that there's a difference in the rate changes between the racial groups. But again, that is only a piece of the picture because, as I said, the non-Hispanic Black rate is starting from the highest baseline. So they went up 21%. Non-Hispanic white went up 16%, but the 21 and 16% weren't statistically different, but they're starting from a statistically different time point, if that makes sense. It's a little hard to explain. Okay, so in terms of our comparison, again, we had two comparison groups. The first was the nationwide comparison, which is going to include all of these blue states. And then the second comparison is just Colorado by itself. So for the 26 protective state comparisons, you can see that there is, again, this downward trend because we want to see infant mortality declining, right? But it does go up, and it goes up around the same time that this change happened. And so there's about a 6% increase nationwide in infant mortality in association with Texas law, which is not the Texas law that's doing it, right? There's something else going on. But we can't attribute the full increase in Texas to the difference in SB8 before and after because of this. So there's something else driving the increase in infant mortality. When we compare the two, the nationwide mortality to Texas, Texas does have a statistically significant 10% higher increase compared to the rest of the country, though. So for Colorado, this is Colorado's data adjusted again for time in both different ways. This looks the same backwards and forwards, right? So there's nothing in this data to indicate that our infant mortality has changed here in Colorado. It's pretty flat. So we don't have anything associated with any of the changes in access. And our trends look pretty consistent here. They are declining a little bit over time, but there's not been an increase in association with the changes in abortion law. So some of the strengths of this study is that time series models are really, really good at assessing change from policy. And because we're adjusting for time in two different ways, that really lets us isolate the effect of the change in law that isn't because we're taking into account whether or not the population itself is changing and any seasonality present in the data, because that does make a difference actually. And then we were able to do a nationwide comparison in Colorado specifically, and we could disaggregate the data sets for race and ethnicity. And then we also did a sensitivity analysis where instead of using a 3-month lag to effect, we used a 6-month lag to effect. It was almost the same, identically. So they're very similar. These results are valid. Additionally, we also did a cause-specific analysis in addition to all cause. And this work is probably, hopefully, going to be published in a clinical journal fairly soon. And as soon as it is, I will be sure to share that information. Some of our limitations. The 2024 data for CDC Wonder is still preliminary, and it could potentially change before it becomes final. In my experience in working with infant mortality data for as long as I have, it doesn't revise down, if that makes sense. So those numbers tend to go up, not down. And one of the things that has happened is that some of those 26 included states have had actually some changes to legal access in the interim. Wyoming's an example. So Wyoming actually has a ban that's on their books, but it's been tied up in court. And if that ban were to be upheld, then we would expect to see changes for Wyoming residents probably coming to Colorado more for abortions and maybe changes to their infant mortality as well. So there is a potential for some misclassification in the cause-specific data sets. And the reason for that is that it's easier to say whether or not an individual died at all than it is to clearly specify what they died of. So there is a potential that some of those cause-specific data sets, my guess would be, if anything, they're probably undercounted, not overcounted. And then there's also potential misclassification in our race and ethnicity categorization. So what happened was for this data is that we had to construct the non-Hispanic other races category because there was missingness in that data based on the CDC Wonder suppression rules. So what we did was we took the total and then we deducted all the other race and ethnicity categories to construct that variable. Even when we did that, we still had small numbers. So because of that, we had wider confidence intervals, and then we have non-significant results. It doesn't mean that the results really aren't significant. It just means that the counts are smaller. And again, our exposure here is really based only on SB8. So it's that 6-week ban. It doesn't include the other types of restrictions to abortion access. And there's no way to account for variability within the state of Texas in terms of access, because Texas is a huge state with a huge amount of variation in access to abortion services. So in terms of public health implications, the big thing to take away with this is that infant mortality is increasing in Texas in association with these abortion restrictions, and that this happened in the 9 months before the Dobbs decision. So this started happening before we lost Roe nationwide. And because of that, and this is the part that always makes me the saddest, Texas results of these findings might become generalizable, because what we're seeing in Texas is kind of the canary in the coal mine, right? Because they did this before the rest of the country did, and we just have more post-ban data available here. But these changes have started to happen in many other states as well. So we would love for this not to become generalizable, but we're afraid that it might be. This data is in agreement with prior published studies, and it confirms the trends that we're seeing. But we're seeing some changes in infant mortality, even among abortion rights protective states. So again, this is where I jump up and down and I wave my giant red flag, because there is something wrong. There is something very wrong, because this is such an important population health indicator. We need to be studying this more, not less right now. And we need to find out what really is driving some of these changes. And ultimately, unfortunately, a lot of the burden for this is going to be shifted to providers, because especially in states with these bans, but even in states with abortion protective laws, we've got to do more. We've got to do more in terms of public health. We've got to do more from the provider perspective, from the clinical perspective. We've got to be able to identify some of the risk factors for why these things might be happening. And we need to be increasing the scope of care, not limiting it right now, especially when we're talking about cuts to Medicaid and things like that. Most of the beneficiaries of Medicaid are kids, right? And pregnant women. And really, ultimately, there are implications about abortion restrictions that extend beyond the duration of the pregnancy. So these are the big things that I want you to take home from this. I want to thank everybody that was involved with this work. And I especially want to thank Dr. Warren Hearn from the Boulder Abortion Clinic. I spent some time over there before they closed. They did close their doors this week. Unfortunately, he retired. But really what keeps me doing this work is all the people at conferences that pull me into hallways and tell me their stories. And that's why I keep doing this, because it is very, very difficult work to do. But it's important. So I would be more than happy to take any questions at the end. And then this is my contact information. Thank you. If anybody wants my resources, I can give you more too.
Folks, feel free to unmute and ask questions. I don't see any in the chat so far, but feel free to still use the chat or unmute. All right, I came with a couple just in case. So I'll try to get the ball rolling here. Thank you, Kelly.
Yeah.
This was great. Um, can you tell us, I had heard about this before, but I'm curious what you can tell us about this. Can you tell us a little bit more about, you mentioned the seasonality of life, death, and abortions. Can you tell us more about that?
Yeah, actually, I've been working with a journal trying to get this research published. And one of the questions that they asked me was why we weren't using, because traditionally infant mortality data is annual, so it's based on a year total, right? And it's the number of deaths based on the denominator being the number of births in a year. We can't do that on a monthly level because births trend differently than the seasonality trends when we're looking at months in deaths. So they don't align because deaths tend to peak in the winter, and then I think there's like one other month during the year that deaths tend to be higher, where births tend to be highest towards the end of the summer. There's a lot of August babies out there, August to October babies. So, so those trends don't line up, but because of that seasonality, like we really had to account for that in order to be able to really narrow down the policy impact that we're wanting to study here.
Great, thank you.
Yeah.
Hi, I have a question. Can you go back and explain again kind of the lag in time that you were talking about, where you said you were looking at like 3 months later, because obviously if something goes in place, the baby's not born yet, that kind of thing. Can you just explain that again?
Yeah, so some of the work that I've done, especially like I've done a lot of travel data for people coming into Colorado for abortions. For that, we did not have a lag. Like the second SB8 change, we started seeing people come to Colorado from Texas for abortions immediately. Like that change was that month. We started to see it. But when we're looking at infant mortality data, we were, trying to think through how to design this, and really, in order to attribute it to the change in the law, we had to give time for the babies that would have been still gestating. You're still pregnant at that point because your abortion access is what we're really focusing on, is your exposure. You still got to be pregnant. And in order for that baby to die and to count that infant mortality as associated, there has to be time for them to be firstborn, because in order for infant mortality to be counted, we need a live birth and then we need a death before their first birthday, because of how that is tallied basically. So for our main analysis, we use 3 months mostly because we, again, we needed to have a minimum number of months before we could really start to count things. But also because 6 months is around the time where you start to see some of the more catastrophic medical complications that people might be seeking later terminations for. And again, there was no exception in the law for anything that was related to the baby, in terms of abortion access. But even in terms of medical and health complications for the pregnant individual, it's really difficult to get an exception granted in Texas. And so that's why we picked that. But we also built models using a 6-month lag just to see if there was a meaningful difference, and there really wasn't.
Okay, thank you.
Yeah, thanks for the question.
Oh, this is Allison. I guess I'm just wondering if there are like any abortions that are still happening in Texas.
Now we say legally no, because right now they're under a trigger ban that they had on the books, that was implemented after Dobbs. So now technically all abortions in Texas are illegal. That doesn't mean they're not happening, right? Because we know that there are people who are still able to get medications mailed to them through telehealth providers that are practicing in shield states. And we know that there's other ways that people can obtain abortions that are maybe not through the legal system in terms of medical authorization and things like that. So yes, there are still people having abortions. Are there people having clinic-based safe abortions with licensed medical providers in Texas? No. Yeah. So, there are a lot of, there's the Guttmacher Institute and We Count, which is Society of Family Planning, both try to have really robust estimates of the number of abortions that are still happening in these restrictive states. But we know that a lot of people are coming to Colorado. A lot of people are still coming to Colorado from Texas, even with the increase in medication abortion, because some people just need procedural abortions, especially if they're past 12 weeks. So they have to have another option. And we happen to be, we're not close, but we're close-ish geographically to Texas. So, yeah, thank you for the question.
Hey, Kelly, thanks for this great presentation. I was wondering if you had any information on how abortion pills like mifepristone are being transported, or is that sort of like gone now because nobody wants to say anything about it?
There are some cases where doctors practicing in other states have been charged with criminal law breaking of variety ways in Texas, but they're not within the jurisdiction of Texas. So what they're attempting to do is to prevent telehealth providers from other states from practicing and then mailing prescriptions into Texas. But at this point, that is still happening. There is probably a little bit of a chilling effect, though, because of the telehealth providers being afraid of legal consequences. Because what's happening now is we have providers that are being charged, and as long as they don't ever visit Texas, they're not under the jurisdiction of Texas state law. And like most of them are practicing from New York, and New York has a really robust shield law, so they won't extradite people to Texas for prosecution of those cases. So yes, there are still a lot of prescriptions being mailed. I think the last estimate that I saw was somewhere in the range of about 6,000 to 8,000 prescriptions of abortion pills are being mailed through the mail from telehealth providers monthly. That's probably gone up since the last time I looked at it. The other thing that is happening is that there are networks of people with shared resources that are, buying them in bulk and then transporting them across state lines through shared networks. And none of that information would be something that you could find on the state public health page, maybe, but if you have connections to people who have those kinds of details, you can still get it. Yeah.
So did that used to be tracked more robustly and now it's not tracked as much then?
Yeah. Well, medication abortion has really increased dramatically in the last 5 years anyway, especially because of COVID. Like, think about how much telehealth changed because of COVID. Abortion is a specific application of the increase in telehealth. So, like, for example, in Colorado, we do collect data from abortion providers in the state of Colorado, but we know we're not collecting everything about all the telehealth providers, because if they practice in Colorado, they may not know that they're subject to reporting requirements. And if they don't practice in Colorado, they're not subject to them anyway. And so we know that we're not collecting all of that data. And that's for a state that's still collecting data. A lot of states stopped collecting data, and there is an argument to be made that we shouldn't be collecting data at all because it might be endangering individuals, especially from criminal prosecution threats in some of these areas. And so the states that are still continuing to collect data are trying to find ways to do it in a de-identified way so that there wouldn't be anything personally revealing being reported to the state, just in case it got taken somehow by another state or federal government.
Yeah, that makes sense. Thank you.
Yeah, thanks for the question.
Oh, Kelly, this is Allison again. Just wondering if there are other data sources you wish you had more access to just to better understand this problem.
Oh my gosh, so many data sources. Yes, in my fantasy world, I would have a lot more data, and it would be real data, and it wouldn't be subject to discovery by other states or the federal government, but that is not the world we're living in at the moment. One thing that I did try to do during my research is that I tried to obtain a lot of data from other states just to compare trends and see if they were seeing like the same increases in travel that we were seeing. Every state I asked for data, I never got it. I made it to a state's institutional review board for one of them, and then they still said no. So even the states that do have data are not really releasing it at this point. And yeah, I mean, I would love to have data. Really a strength of this particular study is that this mortality data is through CDC Wonder, which if you've ever had the chance to use that database, it is fantastic. It's robust. I go back in there and I download my data all the time because I'm afraid it's going to disappear one day. But it's still there for now, crossing our fingers. You know, and there are some questions about the reliability and accuracy of data because it is based on state level reporting to CDC. So there's probably a certain amount of variation in how robust that data really is and whether things are being reported correctly or accurately. We know that a lot of the focus has been on maternal mortality as a result of the changes in abortion law. And one thing that has happened is that some of the states, so maternal mortality is more complicated because you have to have a birth within a certain number of days of the death of the pregnant individual. And then somebody has to make a determination of whether that death is related to the pregnancy itself. And so it's more complicated, right? So that's why there are panels of experts that look through these death records and, decide whether or not this is a case of maternal mortality. A lot of states are just not doing that anymore. And if they're not doing that anymore, then we probably aren't going to get meaningfully correct data for those states. At this point, at least, infant mortality data seems to be, still pretty reliable. And like I said, we're a lot more comfortable relying on the accuracy of the all-cause mortality than we are of the cause-specific mortality. Again, because, if a state wanted to maybe make it seem like there were fewer deaths that were associated with congenital abnormalities in association with this, maybe some of those, maybe there's an incentive for those to not be accurately reported. We don't know that that's happening yet, but it's theoretically possible. But yes, I always want more data. I always want more data, but maybe not right now. Because there is a big fear, of data being in existence, and what happens if those numbers reside in a computer somewhere that is then searchable by other people who have nefarious purposes, right? Yeah, that's the fear.
I see a question in the chat here. It says, have you considered fetal death in your analysis at any point?
I haven't. I know there are a couple researchers that have started working on that. Like I said, the initial wave of research was really focused on maternal mortality, and then all us infant mortality people kind of came second. I have seen an increase in fetal death research. And I'm hoping, in reality, there's a really long list of things that are potential health outcomes that are associated with abortion laws, and we need to study all of them. So this really isn't the time to be cutting funding for research or positions or internships or, fellowships. We need more people doing more of this work. I hope that people will still find a way to do it. Fortunately, the data set that I'm using, at least as of today, is still publicly available and free to access. If it stays that way, I can keep doing this work. If it doesn't, that might change.
We have space for one or two more questions if anybody else has one to get in before we close.
I will just add, if anybody doesn't have another question, in relation to my travel analysis, there was a paper that was published in JAMA Network Open specifically about the changes that we saw for Colorado residents in association with SB 8 in terms of changes to abortion use. So we actually had a statistically significant increase in second trimester abortions for Colorado residents. To my knowledge, it's the first study that has been done yet looking at the impacts on people in protective states. And the only reason that I could do that is because we have good data in Colorado. So we want to keep the data.
We are lucky to live in Colorado for so many reasons. Thank you, Kelly. Thank you so much. Thank you everyone for engaging in that Q&A. Excellent work. I have a couple quick announcements before we go. Any slides or handouts that Dr. Kelly has for us will be in Sketch, so look for them there. Speaking of data, because we are all data nerds, we do have a conference evaluation after the conference is over. Please fill that out, even if you just came to one session. It's super helpful for the planning committee. A handful of things were changed this year based on the feedback from last year, so it works. It's helpful. We've got a 15-minute break. For us, it's 20 minutes. The next session is at 2:45. There's 3 lectures to choose from. Check out Sketch for your options. And again, thank you, Dr. Kelly. Thank you, everybody, for being here today, and we will see you shortly.
Thanks, everyone.
Thank you.